Hello, everyone, and welcome to the Children's Cardiomyopathy Foundation's webinar, Evaluating Children with Hypertrophic Cardiomyopathy, the Importance of Cardiac MRI. My name is Leah Mumm, and I am the Patient and Physician Support Coordinator for the Children's Cardiomyopathy Foundation. We would like to take a moment to recognize our corporate sponsors noted on the slide for their generous and ongoing support of our webinar program and work at CCF. We would also like to recognize our Medical Advisory Board and Chief Medical Officer, Dr. Stephen Lipschultz, for their ongoing support and input in the development of this webinar series. September is Children's Cardiomyopathy Awareness Month. Since 2015, CCF families and supporters from across the U.S. have been forming walk teams to raise awareness of pediatric cardiomyopathy and honor children with this rare heart disease. It's not too late to participate. Please consider organizing your own walk in your neighborhood. To get started, click the link below or scan the QR code located on the screen. The Children's Cardiomyopathy Foundation, CCF, is a nonprofit organization dedicated to finding causes and cures for pediatric cardiomyopathy through the support of research, education, awareness, and advocacy. Established in 2002, CCF has grown into a global community of families, physicians, and scientists focused on improving diagnosis, treatment, and quality of life for children with cardiomyopathy. During today's webinar, questions are encouraged and welcomed. Questions may be submitted via the question box located in the control panel on your screen. We will reserve the last 10 minutes of our time for questions. You are welcome to submit your questions throughout the presentation as you think of them, and we will go through them at the conclusion of the talk. This webinar will be recorded and will be available on the CCF website and YouTube channel in the coming days. Today, we are thrilled to welcome Dr. Charles Canter and Dr. Sonya Kirmani, who will be presenting during this webinar. Dr. Charles Canter is the Lois B. Tuttle and Jean B. Hawk Professor of Pediatrics at Washington University. He is a former president of the Pediatric Heart Transplant Study and member of the steering committee of the NHLBI-supported Pediatric Cardiomyopathy Registry. Current research activities include the NIAID NHLBI-supported study of pre-sensitized pediatric heart transplant candidates, the NIH-supported studies on genetics and biomarkers in pediatric cardiomyopathy within the pediatric cardiomyopathy infrastructure, NIH-supported VANISH trial, and the Panorama Pediatric Entresto trial. He has published over 200 articles on pediatric cardiomyopathy, heart failure, and transplantation, and currently sits on the editorial boards of the Journal of Heart and Lung Transplantation, Pediatric Transplantation, and the American Journal of Transplantation. Welcome, Dr. Canter. Also joining us today is Dr. Sonya Kirmani. Dr. Kirmani is Assistant Professor for the Department of Pediatrics, Division of Cardiology at the University of Wisconsin School of Medicine and Public Health. She is Medical Director of the Pediatric Heart Failure, Ventricular Assist Device, and Transplant Program. Additionally, Dr. Kirmani is an active member of the Advanced Cardiac Therapies Improving Outcomes Network, Action VAD Network, and the Pediatric Heart Transplant Society. She is board certified in pediatrics and pediatric cardiology. Dr. Kirmani's clinical interests include optimizing care for this population in collaboration with the Action VAD Network and the Pediatric Heart Transplant Society. She conducts clinical studies on pediatric cardiomyopathy, heart failure, and heart transplantation, and is involved in the Pediatric Cardiomyopathy Research Group. Welcome, Dr. Kirmani. I will now turn things over to CCF's Chief Medical Officer, Dr. Stephen Lipschultz, for some opening comments. Dr. Lipschultz?
Thank you, Leah. Since its formation in 2002, the Children's Cardiomyopathy Foundation has generously supported pediatric cardiomyopathy-related research, promoting the exchange of ideas, the dissemination of new findings, and elevating the implementation to optimize outcomes and provide the best care to children with cardiomyopathy. Specifically, thanks to generous friends, families, and partners, CCS has awarded 2 grants to Dr. Canter and his colleagues at WashU, who's joining us today. And the award supported their research on the role of biomarkers in cardiomyopathy. Additionally, Dr. Sonya Kirmani, who is speaking today, was awarded a Children's Cardiomyopathy Foundation Senior Scholar Grant. The work that she will be presenting today was supported by the NHLBI Pediatric Cardiomyopathy Registry sub-study on biomarkers, and the concurrent support by CCF enabled that to be successfully completed. Dr. Kirmani received support for her research focused on the importance of cardiac biomarkers and cardiac imaging in pediatric cardiomyopathy. As Chief of the Medical Advisors, it's my pleasure to welcome both Drs. Canter and Kirmani to this webinar today. We're all incredibly grateful for your contributions and impact on the field and for sharing your findings with us today. Dr. Kirmani.
Sounds good. Thank you guys for inviting me to speak. It's a pleasure to be here today. I'm going to quick share my slides. Are we all seeing the PowerPoint?
Yes.
Yes. Okay, perfect. So yeah, once again, thank you for having me today. I'd like to start off with just a bit of background to get us all on the same page about hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is thickening of the left ventricular myocardium without dilation of the left ventricle. And this can be idiopathic or occur with specific genetic or metabolic syndromes. It is associated with an increased risk for heart failure, ventricular arrhythmias, and sudden cardiac death. And it is the second most common cardiomyopathy that presents in childhood. In practice, centers differ on the value and utility of cardiac MRI versus echocardiogram in hypertrophic cardiomyopathy surveillance and clinical decision-making. When we look at these imaging studies, there are some key measurements we are paying attention to. These include left atrial volume, where increases in this can be indicative of restrictive physiology or elevated left ventricular filling pressures, mitral regurgitation and the presence of systolic anterior motion of the mitral valve, septal thickness. AHA guidelines support a septal thickness of greater than 30 millimeters for the consideration of ICD in adults. For pediatrics, this measurement varies by body size and is indexed for Z-score, but the American Heart Guidelines do support massive LVH as a consideration for an ICD. In addition, with imaging, we're paying attention to the presence of left ventricular systolic dysfunction or left ventricular apical aneurysm, the presence of left ventricular outflow tract obstruction or LVOTO, as well as right ventricular function in the presence of right ventricular outflow tract obstruction. However, a key feature that we're going to focus on today is myocardial fibrosis, which is indicated by the presence of late gadolinium enhancement, or LGE, on cardiac MRI. So what does LGE on cardiac MRI look like? Overall, it can be a very diverse pattern and extent of LGE that is possible in our patient population. I did take this figure from a review by Dr. Marin, and you can see these bright enhanced areas in the myocardium of our patients. That just shows the brightness of the LGE as it pops up. And it can be in different locations throughout the ventricle and a different extent and pattern for each patient. So why is this so important? Well, in adults with hypertrophic cardiomyopathy, LGE greater than or equal to 15% of LV mass is associated with increased risk of sudden cardiac death, and now is an indication for ICD placement. We know in a model by Gross-Wortman and colleagues published in Circulation in 2020 that LGE is an independent risk factor for sudden cardiac death in an analysis of 720 pediatric patients with hypertrophic cardiomyopathy. However, the overall prevalence and degree of myocardial fibrosis by LGE on cardiac MRI has really not been well characterized in pediatric hypertrophic cardiomyopathy. I'd like to spend some time and discuss a study that we all did together that was published in the American Heart Journal in 2023 and supported by the Children's Cardiomyopathy Foundation, the Kyle John Rizmozleski Foundation as well, where we focused on cardiac imaging for myocardial fibrosis, as well as biomarkers in children with hypertrophic cardiomyopathy. Overall, we looked at 67 children enrolled across 9 tertiary heart centers in the US and Canada. Our eligibility criteria were children under 21 years of age who were diagnosed with idiopathic or familial hypertrophic cardiomyopathy. Full eligibility criteria is described by Dr. Everett in Progress of Pediatric Cardiology in 2019. Notably, we did exclude patients with syndromic hypertrophic cardiomyopathy. These included patients who had Noonan disorder or RASopathies, glycogen storage disease, and other metabolic syndromes. Any patient with a history of chemo, radiation, history of rheumatic fever, any iron overload or other toxic exposures, pulmonary hypertension, autoimmune disease, and infants of diabetic mothers. The cardiac MRIs were analyzed in a core lab at Washington University, St. Louis, under the direction of Dr. Pam Woodard. Overall, 52 cardiac MRIs had imaging that was suitable for late gadolinium enhancement analysis. The echocardiograms were analyzed at a core lab at Boston Children's Hospital under the direction of Dr. Steve Colin. Our statistics were done in coordination with the Data Coordinating Center at the New England Research Institute, which is now known as HealthCore. Our cohort overall was predominantly adolescent. The median age at enrollment was 13.8 years, and the median age of diagnosis was 12.1 years. It was predominantly male at 78% of our population, and predominantly non-Hispanic with 94%, and the majority being white race at 82%. A bit over half of our patients, 57%, were on beta blockers at the time of the study, and just 10% were on a calcium channel blocker. Our results overall showed that a large number of children had detectable LGE on cardiac MRI, so 48 out of 52 being 92% of our population. 37 out of 52, or 71%, had LGE more than 2% of LV mass. The median percent LGE for our population was at 9%, with the interquartile range being 6% and 13%. Children that were 0 to 5 years actually had the largest amount of percent LGE, which I'll show on the next figure. Adolescents, so children 11 to 15%, or 11 to 15 years, had the lowest percent of LGE. There was no evidence for left ventricular outflow tract obstruction by echocardiogram or cardiac MRI in our population. And the median interventricular septal thickness adjusted for BSA was 11.6 millimeters per meter squared. And as I'll show in the next figure, children 0 to 5 years had the largest amount of septal thickness adjusted for BSA. So at this figure, you can see we've split our age groups. So you have overall birth to 5, 6 to 10, 11 to 15, and 16 plus. And then looking at the different cardiac MRI parameters for percent LG greater than 2%, LV mass adjusted for BSA, LV mass for left ventricular and diastolic volume, LV mass for left ventricular and systolic volume, and interventricular septal thickness adjusted for BSA. Overall, our birth to 5 population had the largest percent LG, both for total and as adjusted for greater than 2% LG of LV mass at 11.5%. And as seen here, 11 to 15 had the lowest amount at 4.5% LG of LV mass in total, and then certainly 8% when we eliminated the less than 2%. And then when we look at septal thickness across all of our patient population, we do see that our birth to 5 population had a high degree of interventricular septal thickness at 18.4 millimeters per meter square. And our next analysis is a Pearson correlation looking at our parameters adjusted for each other. So we're looking at percent LGE in total, and interventricular septal thickness, LV mass for BSA, LV mass index for BSA, LV mass for left ventricular end diastolic volume, LV mass for left ventricular end systolic volume, age at diagnosis, and disease duration. What I really want to highlight here in this slide, however, is that percent LG really was not correlated with any of these LV mass parameters or age at diagnosis or disease duration. However, septal thickness was correlated with LV mass as index for BSA, left ventricular end diastolic volume, and left ventricular end systolic volume, but did not have a correlation either for age at diagnosis or disease duration. We also then performed a Bland-Altman analysis for septal thickness, looking between echocardiogram and cardiac MRI data. Looking at all comers, we did find overall good agreement between echocardiogram and MRI for septal thickness, with a mean difference of -0.2 millimeters, the 95% confidence interval being from -11.7 millimeters to 11.4 millimeters. We did look a little bit more closely at our outliers and noted that a septal thickness of 20 millimeters was an appropriate benchmark. And when we redid the Bland-Altman analysis, we looked and found a mean difference of 2.1 millimeters for the difference, with the 95% confidence interval being -5.6 millimeters to 9.8 millimeters. When we take a look at other published studies for late gadolinium enhancement, there's overall limited literature out there. However, there are 3 studies I wanted to highlight. Chow and colleagues in circ heart failure in 2013 published a study noting myocardial fibrosis in 71% of their cohort. They did not quantify this further. El-Saidi in their cohort found myocardial fibrosis in 33 out of 40 children, so overall 82%, with their median percent LG being 9.7% of LV mass. And then in circ in 2018, Raja and colleagues found myocardial fibrosis in 70 out of 155 children, so 46% of that population, with the median percent LG being 3.3% of LV mass. So overall, we concluded that low levels of myocardial fibrosis are actually fairly common in pediatric patients with hypertrophic cardiomyopathy seen at referral centers. Echocardiogram and cardiac MRI overall show some good agreement with septal thickness less than 20 millimeters. I will note also in our paper, we did do a biomarker analysis with regards to NT-proBNP and troponin T relationships to echocardiogram and cardiac MRI data, and I'll let you refer to the paper for that analysis. Our study does have a few limitations that I'd like to highlight too. Notably, we likely have a selection bias. Our cohort is from major tertiary centers in the US and Canada, as well as a majority adolescent cohort. We did note that children under 5 years of age generally require sedation for cardiac MRI, therefore limiting likely the population that could be studied for the MRI analysis. Our study was not designed to make any genotype-phenotype correlations, as well as we are unable to correlate with risk for arrhythmia or ICD placement. Notably, most children who had an ICD placed was placed for primary prevention. For future studies, it would be really wonderful to look at some longitudinal studies to identify progression of LG in relationship to echocardiographic and cardiac MRI parameters and biomarkers. There's very limited data to understand how the infant population progresses over time as their LV mass changes, and similarly for the adolescents as they progress into adulthood. We do need a better understanding of how myocardial fibrosis predicts sudden cardiac events in children with pediatric hypertrophic cardiomyopathy, as well as understanding the genotype-phenotype correlation for LG and the other parameters studied. And with that, I'll turn it over to Dr. Canter, who I understand is going to take this discussion further.
Well, again, appreciate the opportunity to speak to you all today. I'm impressed on how many people actually signed up for the webinar, so I hope this information will be helpful to you. I think that sometimes when research studies come out, it is often as or more valuable to put them into perspective of how it really impacts clinical practice. And oftentimes that realm leads to the area of opinion and not fact. So what I'm going to try to do today is just give you my take on it and how I see things, and perhaps more importantly, try to relate that to the most recent guidelines for management of pediatric hypertrophic cardiomyopathy that just came out in June of this year. So most of the time when we see pediatric hypertrophy in clinic as part of follow-up, besides obvious problems, like if they look like they have exercise intolerance or chest pain or arrhythmias, is the risk for the big thing that people don't like to talk about, the risk of cardiac catastrophes and sudden death. This study was within the pediatric cardiomyopathy a few years ago. And you can see that in pediatrics, there's a big risk for those hypertrophs that are diagnosed in the first year of life, most of which are not sarcomere mutation and now referred to as hypertrophic cardiomyopathy phenocopies, because they often involve genetic mutations and other pathways besides sarcomere mutations. Sarcomere mutations become more prevalent in adolescence. And if you look here on down, you get out into late childhood and adolescence, you begin to see that there's an ongoing risk of about 0.8 to 2% per year of these catastrophes in adolescence. And oftentimes for most pediatric hypertrophs, this is the area, and this is the issue that we want to try to prevent and evaluate. So currently, there have been in the last 10 years, 2 risk factor studies that have developed mechanisms and scoring systems to determine risk of sudden death and therefore need for an internal automatic defibrillator, an ICD, in children. One, the HCM risk kids evolved from a study that was done out of Canada through Seema Mattel. The other one, primacy, involved Europeans. And if you look at both of them, they include a number of similar variables or factors that are assessed, but you can see they have some differences. But as far as for the purposes of our talk today, when we're looking at imaging modalities, you can see they're all concerned about left ventricular size and thickness, dimensions or size of the left atrium. Those are the things that we require imaging on. And there are other factors as well. As you can see, age, weight, history of unexplained fainting or syncope, and evidence of arrhythmias, non-sustained ventricular tachycardia. But you can see here that the use of imaging modalities is a key component in determining risk in the pediatric hypertrophic cardiomyopathy population. So in terms of measuring the hypertrophy in a hypertrophic cardiomyopathy, there are challenges in the pediatric age group that are often not the same as adults. In our group, there's a conflict between worrying about absolute wall thickness, which is generally felt to be greater than 20 millimeters as severe, and or greater than 30 millimeters, which has been determined a risk factor for sudden death in some studies. But recently, given that children grow at a certain size, and a 6 or 7 or 8-year-old may mean less or more than 1 in a 16-year-old, people have gone to measuring wall thicknesses by z-scores. And all a z-score means is how many standard deviations away from the normal size is a given value. So, for example, if your z-score of your wall thickness is 2, it means you're 2 standard deviations away from the mean. Within the pediatric cardiomyopathy registry, we define hypertrophic cardiomyopathy as having an interventricular septal thickness greater than 2. If it's thinner than normal, then it becomes minus. But again, some folks worry about z-scores, which may be more accurate, but some still use absolute wall thicknesses. But it gets more complicated than that. Then it comes to decide if you're going to use these z-scores, what data are you going to use? Some thicknesses can result in different z-scores using different reference equations, because all of this data is devolved around hopefully large studies of children with hypertrophic cardiomyopathies that then they evaluate, look at outcomes, and then relate that to thickness. But again, there are different ways of calculating z-scores based on thickness, and they are not uniform. And thus it would make sense from just a common sense standpoint that one would need to use the z-score data as those on which the risk prediction model was developed. In general clinical practice, often the z-score models are often used are from Boston Children's Hospital, and neither of those was used in the risk prediction model. So you can see that can be a problem. The final thing is that, again, z-scores are standard deviations, and the higher you get from standard deviations, the smaller the changes in wall thickness occur. So you can have small increases in thickness if you get out on the far end of the spectrum that can lead to very large changes in z-scores, which may have clinical implications, but also are prone to variability in measurement, which is also a challenge in pediatrics. In terms of measuring left atrial size, any assessment of the relationship of sudden death to left atrial size in children is limited by the measurement of how one measured left atrial size. Was it measured by one-dimensional or M-mode echo diameter or of the left atrium, echo left atrial areas, cardiac MRI left atrial volume? And the problem with this variable is that in some studies, as you see, including in Dr. Kirmani's studies, there was missing left atrial depth on left atrial size in many published pediatric studies. Bottom line is left atrial size is not a uniformly measured clinical variable to assess pediatric hypertrophic cardiomyopathy, even though in the risk prediction models, it plays an important role. Now, our two options, what we're going to talk about today are, what imaging modality do you use? And this evolves around either using echocardiography versus cardiac MRI. Both have their strengths and weaknesses. Echocardiography has been around for years, decades. And it has significant strengths. It's non-invasive. It's relatively, and again, relatively, you have to put in quotes because I'm not sure anything in medicine these days is of low cost. It certainly has ready availability, and anybody anywhere in the country, urban or rural, usually can get fairly easy access to an echocardiogram. Echocardiography, however, has some major weaknesses, especially in pediatrics, but they also exist to some extent in the adult world. You could not characterize the nature of the tissue, which is important, as we'll get to in a little bit. You can't distinguish what's scar versus what's good muscle. Because ultrasound does not go through bone, you have to find windows on the chest where there's only muscle to get a view at the heart. Sometimes these windows become markedly reduced in specific situations, such as children who are obese and who are older, may have scoliosis and a number of other factors. So oftentimes you can't get the best echo windows to make your measurements. It is also true that these echo measurements do not have trivial inter, which means between different people measuring the echo, and intra observer, which means the same measurer doing a single measurement on multiple occasions, variability. And this variability can get as high as 10 to 20% for various echocardiographic measurements of left ventricular size and function. So you can see the problem here if you get out to using z-scores, which may have big changes in z-scores with narrow changes in wall thickness. Oftentimes the z-scores may be affected by variability of the measurements, which can affect your z-score and might affect your clinical recommendations. So echocardiography is certainly not a perfect imaging modality. Now, cardiac MRI has been developed in the use in all hypertrophic cardiomyopathies, including pediatric hypertrophic cardiomyopathies, I would say really in the last 20 years. It has many, many strengths in contrast to the weaknesses of echocardiogram. It provides high spatial, not special, spatial, S-P-A-C-I-A-L, and temporal resolution. It can characterize tissue that is scar or fibrosis versus real muscle. It enables images of the tip of the left ventricle or the left ventricular apex and specific areas of left ventricular hypertrophy that echocardiography often cannot see. What the ability to characterize tissue and separate scar from normal muscle has become increasingly important and was in many ways the reason why we pursued MRI studies in the cardiomyopathy registry for our biomarker study that began now about 15 years ago. As because in the adult world, with large number of hypertrophic patients and follow-up, we began to see the percent of scar in the heart that's measured by LGE or late gadolinium enhancement of tissue in a hypertrophic cardiomyopathy left ventricle. And gadolinium lights up scar tissue on an MRI. And then what happens is it says what percentage of the heart muscle or the left ventricle is enhanced by late gadolinium enhancement versus muscle, which is not enhanced. And you can see here that a value of greater than 15% in the adult world was associated with a 2 times risk of major cardiac events, sudden death, in the adult world. And it's based on studies like this, where it said, well, is fibrosis really an important factor that we don't usually measure it in our scores? And should we do this to give another tool to further refine the prediction of what risk may occur for sudden death and allow that to mitigate that risk with ICDs? The other thing that becomes important to a lesser extent that was found in adult hypertrophic patients is by seeing the tip of the left ventricle, you could see little aneurysms in the heart at the tip of the heart or at the apex, which also increase risk of sudden death. The apex is often very hard to see in a large patient by echocardiography. Now, one of the reasons we initiated the PCMR biomarker study is just try to figure out what exactly was or is going to be the role of cardiac magnetic resonance in pediatric hypertrophic cardiomyopathy. So again, this study and a lot of the data that Dr. Kirmani just displayed is basically data that is about 10 to 15 years old when we didn't really know that much about what the role was. And since that time, other studies have been done. And the first thing, not surprisingly, given that MRIs are more reproducible and more exact and have better resolution, is that reproducibility of cardiac MRI measurements of the left ventricle is superior than echocardiography in children. This is not surprising at all, given the nature of cardiac MRI versus echoes. So then people started looking at how with gadolinium enhancement and how much scar. And as Dr. Kirmani summarized there, a number of studies have been done in the last 10 years that say, yes, children can have scar in their hearts. Sometimes it's relatively small amount. The average is about 4 to 6% over all these studies, but sometimes it can be extensive or greater than 15%, which is the cutoff that's been determined in the adult world. So the question when you see it is, well, if you started measuring scar, would that enhance a better prediction of figuring out in children and adolescents what their risk was for sudden death? There are actually very limited studies that have done that. This one was published, you can see, about 4 years ago, where they used MRI data to see how that improved the risk prediction model of an ACE, American College of Cardiology, American Heart Association risk prediction model, and the HCM risk kids. And you can see that a better improvement is on the green line here, and moving closer to the white axis indicates better prediction. And it sees that when they added MRI data in this setting for both using both the American Heart model and HCM risk kids model, there is some modest degree of improvement and predictability for the models. But again, the problem with this study was their endpoint for predictability was a composite of cardiac death, resuscitated cardiac arrest, ventricular arrhythmias, but also appropriate ICD discharge. So many of these patients already had an ICD, and as one knows, with ICDs, sometimes it's hard to determine if an ICD discharge is appropriate or inappropriate. And there is question that if all appropriate ICD discharges, actually, if the ICD had not shocked the patient, would the arrhythmia led to sudden death? So this is not their endpoint here, while interesting, was not particularly definitive. Perhaps the best study that was done in this regard with a large number of patients, as you can see here, the number was about 700, was a study that was presented now 4 years ago at the American Heart Association conference in abstract form only. And in this study, they actually said that qualitative late gadolinium enhancement was an independent risk factor for sudden cardiac death in pediatric patients with hypertrophic cardiomyopathy, and proves the importance of traditional risk markers and risk score and risk stratification in this population. This actually, when it was shown to be presented 4 years ago in the midst of COVID, seemed pretty exciting and pretty definitive. But here's the problem. This has never been submitted to publication in a journal. And what happens often is data that's presented in abstract form has not undergone the scrutiny of peer review by independent reviewers. And so we really don't know much about this study. And the fact that it's taken 4 years and it's still not been put out in print, so to speak, is a little concerning. When we started doing these talks for our webinar last May, I reached out to the authors of the study and asked, well, are you all going to publish this? Because this looked like the type of study that would have no problem getting published. They said they were, quotes, working on it, and it should be out soon. But again, 4 years is a long time to work on something, which raises some concerns that perhaps it didn't look as good as it was presented in abstract form. We don't know, but knowing the authors of it, they're all very reputable people. So it is likely that when it gets published, it will offer data that provides more comfort that actually the degree of fibrosis in a pediatric hypertrophic heart can help predict risk of sudden death. But we have to wait and see for that because it's not definitive at this point. So even though cardiac MRI sounds like it has a lot of strengths and works to counteract some of the weaknesses that are inherent in echocardiography as an imaging modality, it does have its weaknesses. And anybody who's taken a child for a cardiac MRI is well aware of those weaknesses. One, it's time consuming. Most cardiac MRI protocols take over an hour to accurately perform. Also, if you're going to use gadolinium, you need an IV to deliver the gadolinium. It is much more expensive than echocardiograms, which leads to sometimes challenges and conflicts with insurance companies. People need to be still and quiet in the MRI machine to get good images. Children can sometimes not exactly do that quite well. So very often you need sedation and anesthesia to get a proper cardiac MRI to avoid motion artifacts that really negates all of the advantages in resolution of images. The other problem is that as this study has evolved, there is measurement variability from differing protocols from center to center. It's also different in how the MRIs are produced. For example, in Dr. Kirmani's study, we obtained MRIs from all the institutions in the PCMR that were doing MRIs at the time, and we had a common reading center here at Washington University, and Dr. Woodard, who managed that at the time, was the head of the American Heart Association section for cardiac magnetic resonance imaging, so she was considered an expert. And despite getting all these studies from high volume cardiomyopathy centers, there were multiple studies that we could not analyze here in St. Louis because they were not done well enough to avoid measurements. So there's that issue as well. And these are not trivial weaknesses. The other problem has been related into this editorial is just that there are limitations with the current data we have in children, as most of us derive from cardiac magnetic resonance images that were done after one received the MRI or in a retrospective fashion, and work done prospectively, meaning that the study design was done before the study was started, before the MRIs were obtained. This type of variation can lead to missing data and variations in data acquisitions, which will induce heterogeneity in how the studies. Also, given that this data comes from many years, the type of technology in MRIs has been adapted and changed over time. It depends on who's doing the MRI and all the nuances of how to turn the sequences, and also other factors that lead to the imaging. These can be subtle, but they induce confounders that can significantly alter outcomes and therefore conclusions. And whereas echo is routinely applied in clinical practice, cardiac resonance imaging referral continues to be relatively highly selective among physicians and centers, so selection and referral biases are inherently part of the vast majority of retrospective cardiac magnetic resonance imaging studies in pediatric hypertrophic cardiomyopathy. Thus, the limitations of retrospectively acquired data may result in a more limited ability to address these questions at hand and generalize the results of these studies to current clinical practice. Their best use likely is to be a foundation for planning and development prospective studies to address these questions. Those prospective studies remain to be done. So where does that leave us currently? Well, as I said, the American Heart Association and American College of Cardiology recently revised this June their recommendations for management of hypertrophic cardiomyopathy in adults and children. And what's really been great about these recommendations, and this one in 2024 and the first one in 2020, it was the first time that pediatric specific recommendations were given. And so these are the recommendations for MRI use currently as recommended by the American Heart Association. And for the most part, I can summarize these as they show that MRI is complementary to echocardiography and used in times where echocardiography is inconclusive or where there's a suspicion of alternative diagnoses, including things like athlete's heart, which can be thickening, which is a benign thickening versus true hypertrophic cardiomyopathy. Sometimes the MRI can be helpful when echoes and the other factors are inconclusive for risk of sudden death and need for an ICD. Sometimes you get a better handle on obstruction that occurs in hypertrophic cardiomyopathies. But you can see, as terms of routine use of MRIs, remains up in the air. There are some folks that believe that routine MRIs every 3 to 5 years may be helpful, others who are not so sure. But again, the main take-home point is in children and adults, MRI imaging remains a complementary procedure to echocardiography. In a way, in specific patient situations, it can help a decision where echocardiography is inadequate or unclear. As far as how it affects indications for an ICD, again, in children, currently it's recommended that if you have one of the following: a family history of sudden death, massive left ventricular hypertrophy, which can often translate to an intervention, a septal thickness greater than 30 millimeters. Now, if they're using Z-scores, it's greater than 10 to 20 Z-score. Unexplained fainting, an apical aneurysm, or a squeezing ability or ejection fraction of less than 50%. If you have one of those, then they recommend inserting these values into the risk calculators, determine what the risk is for sudden death, and proceed with ICD placement based on if there is more than a low risk. If none of those occur, then people look for non-sustained ventricular tachycardia. And if it's present, then reuse the risk calculator to see where the risk changes. But you can see here that both for children and adults, the use of fibrosis determined by gadolinium enhancement MRI occurs only if all those primary factors don't occur. If it's positive, then you want an ICD is not indicated, or a class 1 recommendation, but may be considered, meaning that some folks would do it, some people wouldn't do it. And of course, if it's not there, then no one would put in an ICD. So in summary, from my take on this is I think that cardiac MRIs can be very helpful for individual patients. I think that likely the amount of scar or gadolinium enhancement in a pediatric hypertrophic cardiomyopathy likely has a role in determining risk. And probably those patients who have higher percentages of scar probably have increased risk, but it has to be determined in the context of other risk factors. Do I use MRI yearly? No, I don't, because one, it's hard for all of these factors. Echo is easy to do, and I think that you use it to help enhance your determination, or if conflicts occur. For example, somebody who has a family history of sudden death, but doesn't have much in the way of hypertrophy or anything else, one might consider doing an MRI to assess scar, determine if they really, an ICD might be the right thing or recommended, especially in younger adolescents, where placement of ICD long-term can be more problematic. But again, this is an area that's actively being studied. What we think about now and what people think are indications in 2024, there's a good chance it's going to change in the next 5 years. And hopefully we'll be able to complete the studies that are needed to better enhance our ability to predict this catastrophic event in children with hypertrophic cardiomyopathy. Thank you all for your attention.
We have now reached the question and answer component of our webinar. If you have questions for our speakers and have not done so already, you can type them into the chat or Q&A box in the control panel on your screen, and we will read them aloud to our speakers. Please remember to keep questions to a general nature, as our speakers cannot comment on individual cases. In the event that we run out of time, we will forward any questions to our speakers offline and return their responses to you. We do have a few questions in our Q&A box. One question is, in children with non-obstructive HCM who present with non-sustained ventricular tachycardia, syncope, sinus dysfunction, what would be some possible etiology and what possible treatment options are available to these patients? Either Dr. Canter, Dr. Kirmani,
Well,
whoever would like to take it.
I'll take that. It's a really good question because quite honestly, non-obstructive hypertrophic cardiomyopathy probably occurs as often or more often than obstruction. If you look at guidelines for treatment, the use of beta blockers or calcium channel blockers is really not recommended routinely in non-obstructive. As far as risk of sudden death, non-obstructives have a risk of sudden death as well. And while obstruction and magnitude of obstruction enters into risk calculations for these scoring mechanisms, it certainly can occur. So for non-sustained ventricular tachycardia, fading, and MRI fibrosis and magnitude of hypertrophy all factor in risk of sudden death in children. The newest drug for treatment in hypertrophic cardiomyopathy, mavacamten, which is undergoing a pediatric study right now. There is data on its use in non-obstructive cardiomyopathy in adults, but the companies that make these drugs have not yet committed to doing pediatric studies in non-obstructive hypertrophy. Those of us who manage children hope they will do that soon.
Thank you, Dr. Canter. We have another question in the chat. For clinicians who are having difficult times evaluating LGE for hypertrophic cardiomyopathy, is there a standardized method for evaluating the gray zone or any other methods you can discuss further?
I'll take that if y'all are okay with that. So I kind of want to give a big shout out to Dr. Pam Woodard, who really analyzed all our MRIs and did it in various methods, to be very honest with you. We went through a couple of reanalyses here as we looked at the different possibilities. We did describe the methods for MRI analysis in our paper if you wanted to refer to that for further information, but we did end up using the 6 sequence method to take a look more closely at it. And then intentionally, we did also do an analysis both with just the LGE and then removing the 2%, because sometimes that less than 2% can be considered artifacts in terms of that. But you are correct that there are actually several methods out there for looking at LG on cardiac MRI. I personally work a little bit closely with my radiology team to understand a little bit better about how they're seeing the LG on the MRI and take a look at the images myself too.
Thank you, Dr. Kirmani. We do have one more question here. If my child's cardiologist were to recommend an MRI with sedation, are there any risks associated with that? And if so, what would some of those risks be?
The risk of sedation, well, I mean, it depends on the patient. I mean, some patients are going to be riskier than others, though most of the time cardiac MRIs can be done and sedated in young children very, very safely and actually become fairly standard procedures. But low risk does not mean no risk. So there's always a problem with sedation. Sometimes MRIs can't be completed because you can't sedate people or there's other issues, which again is one of the weaknesses of cardiac MRIs. I don't know, Sonya, do you have any comments? How are things in Wisconsin now?
Yeah, I really take it on an individual case-by-case basis. I think some folks can be high risk for sedation with cardiac MRI, and then we have to be very cognizant of what information we're going to get out of the cardiac MRI. And other kids are more low threshold for sedation. So I do agree. I think it's individually based, but I always have the discussion with families if we're going to take this on with sedation, why the data is important. Dr. Lipschultz, you're muted.
It's not just the sedation. Some kids with limited renal function, gadolinium deposition disease is something to be thinking about as well. So weighing the risks and benefits of using gadolinium-based contrast in children with other factors also weighs in, but usually in kids without renal impairment, it's a good screening test.
Yeah, and I think the one other factor that I didn't mention is there are in rapid development ways to assess fibrosis in hearts by other methods of measurement that don't use gadolinium, where you can do it without an IV. But there's been no real clinical directed research in relating those type of measurements to sudden death risk. But given the challenges with gadolinium, and they are substantial enough that any research project that uses gadolinium really requires greater institutional review board scrutiny because of its risk. And those studies are generally always considered greater than minimal risk research studies. And so I think everybody who uses MRI wishes there was a way to assess fibrosis that didn't require gadolinium. And likely in the next few years, those techniques will develop, but then one will have to relate those new techniques and how they correlate to the data we have with gadolinium enhancement. But that's, again, yet to be seen.
Great. Thank you very much, Dr. Canter and Dr. Kirmani, for your very detailed presentations today. And thank you, Dr. Lipschultz, for joining us and providing further input. We have reached the end of today's session. Thank you again for everyone who participated. I wanted to once again extend our thanks to Dr. Charles Canter and Dr. Sonya Kirmani for joining us and providing comprehensive presentations on the importance of cardiac MRI in evaluating children with hypertrophic cardiomyopathy. We are very grateful for your time and expertise. The recording from today's webinar will be available on our website and YouTube channel in the coming days, and will also be forwarded to attendees in a follow-up email. In the meantime, please feel free to reach out to us by email or connect with us on social media. Please stay tuned for our next webinar, which will be scheduled for Tuesday, October 29th at 12 p.m. Eastern Standard Time. This webinar will feature Dr. Teresa Lee from Columbia University Medical Center. Dr. Lee will present findings from a recent publication in Progress for Pediatric Cardiology titled Pediatric Cardiomyopathy Illustrates the Importance of Reinterpreting the Significance of Genetic Variants, and she will discuss when genetic testing should be repeated in children with cardiomyopathy. The registration link, along with a link to her paper, have been placed in the chat. Again, please consider organizing your own walk in support of Children's Cardiomyopathy Awareness Month to raise awareness of pediatric cardiomyopathy and honor children with this rare heart disease. Please scan the QR code on your screen to get started. Once again, thank you to our speakers for this very informative webinar on the importance and role of cardiac MRI. Thank you everyone for joining us. Have a great day.